That's great. Thank you all. You're prophetic. You're the things we're going to talk about. You touched on. I'll tell you what we're going to do. For the next bit of time, I want to talk about early stage recovery, specifically how that impacts the couple. Okay, and then we're going to shift over to where Colleen's going to be talking about middle and later stage recovery. And the work that's possible in the first stage is actually necessary as a foundation for what happens later, and how important it is to keep these straight. So I'll be talking some about the effect of addiction on the brain, including in early recovery, that put some limitations on some interventions, open up other possibilities, but then we can point hopefully towards doing deeper level work. So we're going to be covering early through middle stage recovery today, specifically applied to couples, and we're calling that plural recovery, okay?
And I just want to say one thing too, is that while Bob and I are presenting, if you can keep Susan and John in mind.
Yes.
Okay, like actively thinking about them as a couple, how does this apply and how might it not apply?
Good.
That would be great.
We're actually talking about this in terms of relapse prevention for couples. The idea that it's impossible to think of the addict in recovery separate from, we'll be using the image of the non-addicted spouse today. We can talk about any significant other, but we'll be talking about that probably typically, I'll be talking about in terms of a heterosexual couple, that any couple in relationship, the most significant other, and that it's impossible to separate out the recovery of the one from the participation actively of the other. And you'll see that assumed in what we talk about. So we want to talk about, first of all, stage 1 recovery, and for shorthand, I'm going to just call that getting sober. Once the addict enters into treatment, all of us have run into this, is that the non-addicted spouse is what? They're burnt out. Any comments on that? What kinds of things have you seen in the non-addicted spouse that represent some version of burnout? Any comments on? Yes, ma'am.
Codependency.
Codependency, okay. Where there's incapacity to separate. Someone else? Yes. Anger / resentment. Why wouldn't there be? With all the wreckage, all the water that's gone under the bridge, how many of you have seen this scenario where somebody enters into treatment, the addict enters into treatment, develops a strong kind of launching pad for taking sobriety seriously, comes home assuming that the family is going to have arms open wide, happy, 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 and finds out that there's a lot of anger, a lot of resentment, very understandably. One other comment? Yes.
Maybe feelings of hopelessness, depending on maybe how long the drinking or.
I want to talk today, this morning, or excuse me, this afternoon now, I want to talk about realistic expectations that can engender hope, for sure. Notice I say realistic expectations versus non-realistic expectations, but that clients come in and they're demoralized. Yes, there was a hand back here. Yes,
there's also some detachment sometimes.
Yes, yeah. As a response to, let's say, is almost the flip side of anger, is that I'm not going to feel this kind of anger, this kind of anxiety. I'm not going to be codependent. I'm not going to worry. I'm just going to detach. And so you get emotional cutoff. Absolutely. I'm ready. The significance of this that we're talking about in terms of the couple and specifically around the non-addicted spouses burnout is that we know from addiction research that the #1 trigger for relapse is stress. And we know from recent research in the last 10 to 20 years in attachment theory that the #1 stressor for most of us is relationship stressor. So you can do the math on that, right? #1 trigger for relapse is stress. #1 stressor is relationship. So we must attend to this. It is vital in early stage recovery, and we had a lovely lunch day with some friends that we just made. It is vital in early stage recovery in order to address the hopelessness of the non-addicted spouse to provide authentic support. I just gave a presentation this last weekend at a conference here in Los Angeles, the Evolution of Addiction Treatment Conference, and presented on motivational interviewing. Motivational interviewing is set up to prepare those of us that are helpers to match the client's experience where they are, not behind it, not in front of it, right where they are. And so I would gear you towards studying motivational interviewing insofar as if you have that, to restudy it, okay, because it's a way of lining up. And if you don't align with the non-addicted spouse, I'm thinking of the interventionist Burr Cook. Some of you know Burr Cook. We had a conversation a year ago, and he says this is what he tells families when he's working with them in and around recovery. He says, if you, talking to the non-addicted spouse, if you do not enter into your own recovery, your husband or wife will die. That's what he tells them. That'll get your attention in a hurry. But what we're talking about is if you don't provide support, and that includes, well, we'll talk about what that includes in just a minute. If you don't provide adequate support for the non-addicted spouse, you're going to end up with the husband, the wife, the son, or the daughter dying because they're isolated on the vine. And they're left with somebody who's pissed off, angry, resentful, hopeless, enabling, all of those things. And so that must be addressed. I mentioned earlier that part of the support that must be offered, and I'm going to talk into this for just a few minutes now, is to provide some kind of roadmap for what the non-addicted spouse might expect. This is what you all are doing in your work right now online in Florida. And coupled with information is to provide some kind of roadmap that provides some kind of realistic hope and also realistic expectations, because one of the things that happens in my experience is that someone can go away to a rehab, to an intensive outpatient, and you'll have the family at home with really unrealistic expectations about what their father, their mother, their husband or wife, how they're going to be acting when they come out. So let's talk for just a minute about what happens in the brain, in and around addiction, including early recovery. We'll talk about this in terms of post-acute withdrawal syndrome, or PAWS. There's plenty of information that's come in the last 10 years owing to brain scans where we can look at the neuroscience of addiction and understand that not only is the addict's brain significantly altered by substance, but that afterwards it takes between 6 months to 2 years is the general rule of thumb in the literature on post-acute withdrawal syndrome. 6 months to 2 years for that brain to recalibrate. So in the meantime, what you see is what? You see cognitive oscillations, up and downs. You see emotional ups and downs. You see motivational ups and downs. And I just thought of this the other day. You see energetic ups and downs, just in terms of physical energy that's accessible. And it doesn't go away when I leave rehab. I'm just beginning that. And so you have this kind of, God willing, you have this kind of gradual resettling or recalibrating of the brain, but it takes a lengthy period of time. In the midst of that process, you're going to get some good days, and you're going to get some bad days. And this is where it can go sideways for couples and families. When the addict comes home, they're in pause, and the expectation is now that they're sober, things should be fine. It's one of the assumptions of this first stage work that without an adequate biological foundation in the brain, in the body, there isn't sufficient psychological structure to do some of the deep level healing that's required for a relationship to move through more advanced recovery. Does that make sense? It's a mouthful. If the addict's brain is still off, you don't have enough critical mass to do the kind of work that's required for deep level healing of the ruptures or the wreckage that transpired in the addiction. And so to move prematurely into deep level work with somebody whose brain is like this is to court disaster. Why is that? You get the couple in counseling with you, and let's say you're having a bad day, a bad week, a bad month, and you're trying to do repair work with one individual who's really hamstrung, brain-wise, and expecting that they're going to be able to perform. At the very least, what you're going to do indirectly is shame the addict. You're going to shame the addict because he or she can't get their act together. And on top of that, you're going to be setting a tone for the non-addicted spouse to expect a level of performance that's completely unrealistic, right? Does that make sense? Just to give you a quick little touch of this, what goes on in the brain during pause? And I'm going to cover 4 brain systems. Colleen and I give this presentation, a 2 or 3 hour presentation. We just gave this on Saturday at this same conference. It was a 2 hour presentation. 2 weeks before that, we presented at a local university where it was 3 hours. And so today you get the Reader's Digest version of the brain. Okay, if we had more time, we'd go into more detail. But at least I want to touch on it so that you can get a sense of what is operating in the brain during pause. And I also want to reference you to the bibliography, because in our bibliography I listed about a dozen references that are all quite readable. Most of them are quite readable on what happens around addiction in the brain. So if you want to do a refresher course, good books in the bibliography. 4 brain systems then. The first system we know about, if we've been working in addiction, is the dopamine system. The dopamine system is responsible primarily for 2 different behaviors. The first one is salience. That's a fancy word for picking out what's important in the environment. How do I, out of all the things I have to attend to, how do I pick out what's most important? The dopamine system is instrumental in being able to do that. And secondly, related to that, is once I picked out what's important, the dopamine system motivates me to seek it. Okay. Well, as you can well imagine, in addiction, including in pause, in the 6 months to 2 years after addiction, after abstinence or after sobriety, literal sobriety, you still have a brain that is oriented towards picking out drugs, picking out the addiction, as that's the most important thing. And it's wound into motivating us to move that direction, hence all the cravings and so on. That takes months, sometimes years to recalibrate. That's the dopamine system in a nutshell. The second system is the opioid system. The opioid system, we have an endogenous opioid system, endorphins, that help manage or help control our pain. Not just physical pain, but emotional pain. So what happens if I've been relying on alcohol or heroin to manage my psychological/physical pain? You pull that away, now I've got all of this pain and I don't know how to manage that. And it takes months or years to be able to recalibrate. Thinking of an associate who's an interventionist who talks publicly about this, it took him years after a long-term addiction to prescription painkillers to get to where he could stand being inside of his own skin. There was such physical pain going on for him, much less the emotional kind of corollary of that. So in terms of managing pain or relieving pain, another aspect of the opioid system that's talked about less that I think is more important in many ways, and Colleen will be talking about this, is that the opioid system is what connects us to one another. It's what's released when we connect to our children, to our loved ones, and that's gone all haywire in and through addiction. And it takes a long time for relational connection to compete with what the substance provided me. My lover was the heroin. My best friend was the alcohol. And now you're asking me to give that up. And you've got an opioid system that's wound into that. So the opioid system needs time to heal. The third system is the self-regulation system. Focusing for just a minute on memory. Self-regulation system is what remembers, locks in memories of, especially around cues, drug-related cues. And so I've got a massive amount of my psychological or mental real estate devoted to remembering and responding to those cues. It takes a long time to extinguish or fade, for those memories to fade. It doesn't happen overnight. And then secondly, with the self-regulation system, it's our frontal cortex and fibers that radiate from this part of our brain down to the middle of my brain, the limbic system, that help to regulate my impulses. And primarily I'm thinking here of aggressive impulses, so look at what, and sexual impulses. Look at what happens if you prematurely move into relational counseling at a deep level with somebody who's in and out of rages just because the brain is trying to settle itself and is incapable of handling those impulses. And even if you get a client or a couple that come into your office and they're amazingly polite in your office, which is hard to do when you're doing intense psychotherapy, what happens when they go home? You've got an opioid system that's out of whack, self-regulation system that's out of whack, and you've got somebody raging at home, incapable of containing the rage. The fourth and final system is the stress system. For so many of us in and around addiction, if you've been addicted yourself or have clients that are addicted, is it not the rule, with maybe a few exceptions, is it not the rule that that person has a load of trauma in their lives? Developmental trauma, sometimes single instance trauma, but oftentimes long-term trauma. The substance is how we manage the cortisol and adrenaline that are stirred by the trauma, right? Guess what happens when you take away the substance? Now I'm left with cortisol and adrenaline. The example I gave the other day is I had a client who said, "Bob, I'm sick and tired of barbecuing in my own adrenaline." And what she was saying, she was an Arent. What she was saying, she was knowledgeable about what's going on physiologically. What she was saying is, owing to the trauma past and present in her life, without substance, she was literally barbecuing in her own adrenaline. So that's the trauma aspect of the stress system that's out of whack. And then finally is the big fancy word, allostasis. And I'll translate this. This is where the poor get poorer. The idea being this, is that when I take in a substance, let's say like alcohol, I take in a substance like alcohol, my body, in order to regulate itself with that much opioid and dopamine activity in the brain, the body to regulate itself ups what? It kicks in cortisol and adrenaline. What are those? Those are stress hormones, right? And so in order to balance the brain, my body naturally will kick in stress-related hormones just to kind of balance things out. Guess what happens when you take the alcohol out of the equation, or whatever the other substance out of the equation? You've got this massive influx of stress-related hormones going on. Allostasis is our friend until it's not our friend. Allostasis is the regulation that goes on in the brain. If you take out one side of the teeter-totter, the other side flips up, and you've got a serious problem in terms of barbecuing in your own adrenaline. Okay, so, in essence what we're saying, if I could just crunch it down, is that the brain of the addict and the individual in early addiction recovery has been hijacked. I've talked about 4 brain systems and 8 brain-related behaviors. That's a start on explaining how off that brain is for a significant period of time. And it's easy to forget because what happens, you can have somebody who presents intellectually really present. They're actually able maybe to work in a work situation and be functional. It's deceptive, isn't it? You have somebody who's really intelligent, maybe very successful, whatever it might be, and when it comes to dealing with stress, that's where it shows up. When it comes to dealing with relationship, that's where it shows up. So we have to be careful not to be fooled to think that the addict is further in their recovery than their brain is. Does that make sense? Make sure that you don't be deceived by that, because it's an easy way to mistake things. How this affects working with couples in stage 1 is that there are certain capacities that are hamstrung or have been hijacked. One of the capacities is the ability to reflect. So I'm in therapy with you, and you're asking me to self-reflect. Well, that assumes that I have a brain that's capable of that. We just talked about 4 brain systems that are really out of sync right now, and that's going to be a dicey proposition at best, especially earliest on. And so what you'll see instead of self-reflection is reactivity. I don't reflect, I just get pissed. I react, I lash out. Another capacity that is desirable if you're going to be working with a couple is the capacity to empathize, to step into the shoes of one's partner, which is very difficult to do when your brain is wired at this point just to win. I'm not interested in knowing what's going on for you. I just want to make sure I come out on top. And someone has said that addiction is regressive. This is how it's regressive, because it may be that you have the capacity to empathize pre-addiction, but in addiction and post-addiction, you may well have lost that capacity. And part of the accomplishment of recovery is to rekindle that capacity to empathize. The ability to forgive oneself. That requires all kinds of higher cortical functioning to be able to forgive ourselves. And what we're left with instead is what? Shame. We stigmatize ourselves. And so in the role play that Colleen and I did as John and Susan, she's registering complaints about what happened, registering her pain, her sorrow, her anxiety. And what did I say to her? Oh, you're just guilt-tripping me again. That's a brain that doesn't have a capacity to forgive myself. She's naming things I know I did wrong. I should have had my phone on vibrate. I didn't. And now I'm busted, and so I respond defensively. And then finally, the capacity to express genuine remorse. For deep level repair of the ruptures that have come from addiction, you've got to get to this place to be able to express genuine, heartfelt, tearful remorse. And to expect that of somebody early in recovery is to really push the limits of what their biology will create. Even with the best of our biology intact, we can think how difficult that is. Us in the room here, it's not an easy thing to express genuine remorse without shame, with empathy, the ability to self-reflect. And so imagine what it's like if you're in the midst of your brain trying to get back to square one again and then asking for me to express genuine remorse. Ain't gonna happen. That's the bad news, okay? The good news, what can be done in early stage recovery? I'm gonna go through this quickly. Those skills, by the way, that I just talked about are all skills that are necessary for moving into stage 2 recovery, which Colleen is going to elaborate on in just a couple of minutes, which focuses on healing relationships. Every one of those skills that I just talked about is required for this stage to happen. So do we just sit around and twiddle our thumbs until we're ready for this? No, we don't. So here's some things that can be done in early recovery, and my guess is that many of you are doing these things. It's just to be clear, if I could make a statement, it would be, to be clear on not pushing things beyond what's capable. Doesn't mean that you stand around, but I'm wanting us to be mindful so that we don't do something that sabotages the therapy. And if you get the cart before the horse, that's what's going to happen. You're going to sabotage the therapy. So, in stage 1 recovery for the addict, these are things we all know about. First of all, you need to get a commitment to sobriety, and it's not enough to have a verbal commitment. It needs to be a behavioral commitment, right? And so this includes, to my mind, involvement, working the 12 steps with a sponsor in the program. It includes psychotherapy. Somebody mentioned psychotherapy for the non-addicted spouse. Certainly psychotherapy for the addict in recovery. We talked here earlier over lunch about mindfulness, meditation, some prayer, some means of being able to develop that self-regulation that's so off, and I think it's a critical piece. And then finally, involvement in a community of like-minded folks that are really walking the same walk. How about for stage 1 recovery for the significant other? They need to be, we've already made this point, they need to be involved as much, right? Here's some possibilities. AlAnon, 12-step involvement for the non-addicted spouse. Psychoeducation, which is a big word for what we're doing right now. Talking about addiction in the brain so you can give some kind of meaning to what's happened, and also some kind of roadmap that supplies hope about what's possible in the future. And I recommend rooting that in the good stuff that we have from information about addiction in the brain. And then finally, a process group to be able to process all that's going on in and around reacclimating to the addict being back in the home again. There needs to be a group that supplies support for that as well. And then finally, stage 1 recovery for the couple. What does that look like? The term that Colleen and I are using, we call this foundational couples counseling. It isn't that you don't do couples counseling, but make sure that it's about supplying a foundation for the stage 2 work to come. And what goes into that? The primary thing is that you try to get the couple to begin to work together to realize that they're fighting a common enemy. It's not Susan and John against each other, it's Susan and John against addiction. It's about Susan and John towards recovery. So begin to focus on identifying the conflicts that come up and externalizing the problem. That's the addict in John. That's the AlAnon in Susan. And what can we do to join together to begin to identify, this is where we want to go, and at least establish some understanding of what happened in addiction. And I think that the information on neuroscience can really help that. Is you can begin to understand, I'll make one final point, and that is, there's a distinction in psychology between a dispositional attribution where you blame it on the person. It's your disposition, it's your character, and you're to blame. You're bad, bad, bad. There's a distinction between that and making a situational attribution. A situational attribution is this. It's externalizing the problem and realizing that under the influence of whatever the substance was, this is what people do. Not okay, but it's not about you being a bad person. Let's not shame you. That'll just paralyze you. Well, why don't we shame the addiction? Let's externalize the problem and attack the addiction. And that's moving from a dispositional to a situational attribution. Okay, with that, Colleen/Susan, thank you all.
So I just want to talk for just a few minutes about this earlier stage, the foundational stage, and just kind of flush that out a little before I go into the next piece, which is really looking at this through an attachment lens, the attachment theory. But if we're going to work with the couple now, when John is still kind of reactive and Susan is still really pretty terrified, how are we going to help calm them down? How are we going to help them to get through this period of time? And one of that would be, are they both seeing the same thing? In other words, there's this really negative cycle that gets kicked up, and it could start with John or Susan. When Susan starts to get worried, what started her, before John came home, she had hours of worrying and fretting and freaking out and remembering all the times that John, so she was kind of having like a PTSD response when John came in. And what did John do? You're overreacting, right? So underneath Susan's controlling and wanting to find out where John was and being so, was really what? Fear. Fear, right. Panic, right? And for John, John was in a reactive kind of like, you're making too big a deal out of it. Are we going to continue to go back to that? Why do you keep breaking me over the coals? He was defensive. What's underneath defensiveness? Shame. He doesn't want to remember all those times that he let her down. And so when they get back into this place where Susan starts to control and question and maybe even look like criticizing, John then tends to get more defensive, more pushback, and the more defensive and pushback John gives, the more Susan feels like, here we go again, right back how he was. This was how he was during all those years of using. It hasn't changed. And then she gets even more angry and ups the ante. And can you see how this is an interactive feed loop between the two of them that leaves them both what? Further and further away from each other. So can we just name that in the therapy room? So every time this happens, so they're both like, yeah, we don't like that. Susan feels horrible. John ends up feeling like, stomps off and is angry and upset. And neither one of them, so if we can kind of get them on the same page, are they seeing the same thing? Can we agree that this is not a good place for you guys to go? So naming that together is really helpful. Can they see the same landscape, right? So when you're outlining the more John tries to say, Susan, what's the big deal? The more she gets even crazier, right? And says, John, you're only 3 months, you know what I mean? I'm still panicked. And so at this stage, you want to stop. They're seeing each other as the bad guy. Susan's too controlling. John's so defensive. And so you want them to sort of see that this cycle leaves them both feeling alone and disconnected. So we kind of talked about that a bit. So what I'd like to do, well, first I want to say AlAnon and AA, and we just are using those because those are such big models out there and they're big go-to places, but we're not advocating that it should be AlAnon and AA. I'm just going to use those as one form of recovery that they can both do individually. So AlAnon and AA can help each member of the couple see their part in the recovery process. It gives them a chance to see how they might be contributing to their own distress. What do they have power over and what don't they have power over? So this kind of self-reflective capacity that Bob was talking about is really necessary to do repair work between the couple. But this does not give the couple a map for how to deal with triggers, conflict, or even how to mend hurts. They don't have a map for that. And if you can imagine John or Susan talking about maybe their character defects or how they might have let their spouse down in a group, in a supportive group, or with their sponsor, or with their therapist, how is that different than dealing with that together? Can you see how dealing it in a context of a safe environment as opposed to with a reactive spouse or a defensive spouse? How that's a very different process. And we shouldn't confuse those. So just because John can go to his individual therapist and say, I know I let her down so many times. I know she was, she came to the hospital and I saw the tears in her eyes. I just thought, oh my God, I can't keep doing this. But was he doing that in that moment? No. And what about Susan, that she says, I see that John's trying so hard in his sobriety. I'm so proud of him. I think that's really great. I'm really afraid that we're going to go back there, but I can see he's trying. Did she convey any of that to him? So this is really more realistic, and that's what we're trying to do. We're trying to kind of look at this picture in a very realistic fashion. So now what I'd like you to do is take off your addiction lenses and now put on your, who knows about attachment theory in here? Does anyone have any background? Some people, okay, let me just say in a nutshell, there's about 6 decades of research and study in attachment theory. And originally it was looking at caregivers and their children and caregivers. But this research and study is now generalized to adult love relationships. And we now have a good 3 decades of really robust, really significant research on what makes adult love relationship works and what doesn't. And one of the forerunners in this field is a Dr. Sue Johnson, and she's developed an approach called emotionally focused therapy for couples. And she has 25 years of research behind this model. And this research is pretty impressive. It says that 75% of couples who come in distress move from distress to recovered, and that is sustained over time. And 90% of couples who undergo, it's called EFT for short, is they show significant improvement, and that's sustained over time. So Bob and I are taking that model and that way of working and applying it very systematically to the couple who's struggling with one member who's in recovery. And we're looking at when to do what interventions at which time, owing to post-acute withdrawal syndrome, owing to how much education and support the loved one has gotten. So I'm going to call it the loved one and the person who's addicted. So I want to look at a little bit of the research from adult attachment theory, and I want you to think about it now from think about John and Susan from this perspective. This first idea, you really don't need any research to back this up, I don't think. And that is that love relationships are powerful, and they evoke powerful feelings. Anyone who's been in a love relationship can attest to this fact. And what we do is we co-regulate each other in both beneficial and harmful ways. So in other words, even as I'm standing up here speaking, if I see some of you like checking your phones, or if you start whispering, or even worse, you start whispering and you start laughing, that's going to affect me, right? I might lose my place. I might suddenly like become like worried and are they getting? And so right now we are co-regulating. And this is never so much as with a romantic partner. They read each other constantly. You're constantly reading each other and impacting each other. So we have a huge effect on each other emotionally, physically, and psychologically. Another important piece is that the brain registers physical and emotional pain in the same way. So you know that saying, sticks and stones can break your bones, but names can never hurt you? Well, it's really not accurate. And anyone who has been in a long-term relationship and broken up knows, or has had a really bad fight with a significant other. That is painful, right? That is painful. So why are these love relationships so powerful? And I'm just touching on decades of research here, so I'm going to just give you a couple bullet points for you to think about in relation to John and Susan. Because a lot of times, the loved one of the addict, people say, oh, she needs to do her own work, or he needs to do his own work, or they need to get into AlAnon. But they're hurting. They're hurting, and they're not being understood either. And I think attachment theory, if you look at it through this lens, you can understand why they're in so much distress. Susan might look like she's unreasonable in that in our role play, right? But there is really good reason why she's in distress. She may not be articulating it or showing it in the most productive manner, but there are good reasons why. So what we do know is that these needs are wired into us and are instinctual. The need for a close, loving relationship is lifelong. It's with us from the cradle until the grave. And not only is it with us, but it's the most important factor in people leading meaningful and happy lives. And this is what the research is telling us. There's a great documentary out there called Happy. It was out, do you know it? Yeah, it came out I think in 2007. And it's beautiful. It actually has a lot of really cool research, but it's done very in an entertaining way. And if you ever have a chance to look at it with your loved one, you'll hear a lot of what I'm talking about here echoed in this. And they look at people all across, all over the world, all different socioeconomic backgrounds. And what is one of the biggest common denominators of people being really happy? Close, connected relationships. Is there any reason that the loved one who's coming into the addict is in such distress? Another important piece is that these relationships impact us physically. There's a gentleman by the name of Bert Uccino out of the University of Utah, and he has done a lot of research in this area in adult relationships and the import of them. And he says that a good relationship is the single best recipe for good health and the most powerful antidote to aging. And with 20 years of research with thousands of subjects shows that the quality of our social support predicts general mortality, as well as mortality from specific disorders like heart disease. In fact, emotional isolation is worse for your health than smoking. It's worse for your health than not exercising. Why is the #1 punishment in our penal system is solitary confinement? There's a reason. It's debilitating. So we are wired to be loving and connected, and that's what we're kind of, in terms of mental health, close connection is the strongest predictor of happiness, much more so than making masses of money. So another important, this is an interesting distinction. In attachment theory, they don't really look at people as being overly dependent. Instead, they look at it as effective dependence or ineffective dependence. And secure or effective dependence is really helps us to be more independent. In other words, the more securely connected I can be, the more autonomous and separate. The more securely connected I am in my relationship, the more I can risk and go out in the world. Have you ever felt what it's like when you have a big fight with your significant other and then you go into work? You ever feel kind of off balance, just don't feel right, get that feeling in your stomach? Or what about when you have an amazing weekend together, you feel really good, and then you go off into your days? You feel better, right? Yeah. So, what is the foundation for secure dependence? I want to talk about another study which was done out of the University of Texas. And they looked at what is the biggest, it was a big study, and it really was corroborating a lot of what was being done in adult attachment research. And they looked at what is the biggest predictor of a successful marriage 5 years into it. What is the biggest predictor? What do you think they came up with? Any thoughts?
The couple was happy before they met each other.
Ah, the couple was happy before they met each other. Okay, that's one. Anybody else?
Open communication.
Open communication.
Friendship?
Friendship, yeah. These are all really important pieces, yeah.
Generosity.
Generosity, I like that. That's nice. Generosity, yeah.
Mutual respect.
Mutual respect.
Trust.
Trust, yeah. It's a biggie. Trust. And what do you think John and Susan have around the trust issue? That's a little shaky, yeah? Did you have your hand?
Oh, I was going to say commitment.
Commitment, oh yes, yes. It kind of helps to add to the security. Okay, the biggest predictor in a nutshell. Emotional responsiveness. You missed your opportunity. Almost. I knew you had it. Emotional responsiveness. Basically, underlying most fights, when couples come in to see me, underlying most fights are these 4 questions. Can I count on you? Will you be there for me? Do I matter to you? And am I valued by you? If the answer is yes to those questions, we can work out differences in sex. We can work out money issues. We can work out, if we really know that the answer to those 4 questions is yes, that gives us a foundation to work on it. If I know my partner is going to be emotionally responsive, I can hang in there with them, even when we have a disagreement, right? So what happens to this when addiction takes hold?
They don't feel any of that.
Right, exactly. They don't feel any of that. Susan's sunk. She's crying out for help. That angry, reactive, where were you, is coming from stress, right? And John's just getting his sea legs. He's just figuring out what it's like to be sober, let alone having a barrage of questions, which he may be able to do when he's in a supportive group, but then when he's with the person who matters the most, You know how much is at stake? Right? So much on the line. So, I'm actually good, yeah. I'm so worried about not having enough time. I just spent through all that. So maybe I could ask, maybe we could bring back sort of John and Susan, what we did. Yeah.
Can you repeat those 4 questions again?
Sure, I'd be happy to. So underlying most fights, couples are really asking each other, can I count on you? Are you there for me? Do I matter to you? And am I valued by you? And if you think about it, really, if Susan really knew that, yes, she could handle it, that he didn't have the phone on, you know? And John, if he really felt that, I think that fight would look a lot different.
Why don't we open it up for comments, questions, breaking TVs? Open up for any thoughts that you have. You all are working with individuals in recovery, you're working with families and spouses, and let's have a dialogue for the next few minutes.
Yeah, let's go and do that, and then we'll talk about the endings.
Yeah, okay, all right, so just
Steve, you can talk about the brain science of relationships, because when you have a good relationship, the things that happen in the brain are just amazing.
Yes, that's right. There's an unbelievable study, a groundbreaking study that Sue Johnson just did, where she looks at, let me see if I can recreate this. She takes couples that are in distress and she puts them under an MRI. There's a lot of research protocol that goes into this, so don't get too worried. She puts them under an MRI machine, and they used a woman and their spouse that happened to be heterosexual couples, and they gave the woman a shock. They said, when you see a light go off, you're going to get a shock to your feet. It was just a little shock. And so you could watch the brain would go all light up in fear. It was just like a Christmas tree. It would light up in fear when they said you're going to get a shock. Then they had her hold the hand of the technician, and there wasn't much difference. And then they had her hold the hand of the spouse that they were not doing well. Remember, they were coming into couples therapy, still lit up in fear. After going through a whole treatment protocol with the emotionally focused therapy, they underwent the same thing, watched the brain, and again, when they told her about the shock, her brain lit up, and then when they had her husband, after the therapy, hold her hand, the brain barely lit up. She was okay. So actually, when you have a secure, connected relationship, it can change the brain. I just want to mention one other study, which was out of, this was done at the survivors of 9/11. And they looked at people who were somehow involved with the crash or close to the epicenter. And there was a gentleman by the name of Chris Frawley who did this. And the people who did the best, who got through this horrible event with the most resilience, were people who were in long-term, supportive, love relationships. And not only did they do the best, but they actually did better afterwards, because the support from their partner helped them to make decisions in their life to lead their lives in a different, more productive way. And so just a couple of, that's sort of the brain on love, and how that gets so derailed when addiction takes hold of the couple.
I remember my first course in social psychology a very long time ago, and we talked about social or emotional contagion. Who of us doesn't know how that goes? How is it that we catch moods from each other, don't we? I mean, we share this all the time. To be in the presence of somebody who's mindful and present is such a radically different experience than being in the presence of somebody who's irritated or anxious and impatient and so on. And certainly in our most significant relationships, that's way the case, isn't it? You can just rehearse your own experience. How incredibly soothing it is to be in the presence of somebody who's carrying their own centeredness. I think it's on us. Colleen and I have both done a lot of training of therapists over the years. I think it's on us as therapists, it reminds me of our conversation at lunch, that a primary responsibility for those of us that are caregivers is to keep ourselves centered because of this reason. Because as Colleen said, we do co-regulate each other. Sometimes I think it's the most important thing we can give to clients. There's therapy outcome research that looks at the end of therapy, you interview people for how'd the therapy go and what made a difference to you. And never, ever, ever does anybody at the end of therapy say, you know, It was that great theory that he shared. It's never ever that. What is it? It's the day that a tear formed in his eyes, we were talking. Or it's the day that we burst into laughter spontaneously. Those are the things that matter, and that's all about co-regulation, isn't it? Those are those healing, pivotal moments in therapy for all of us. Yeah, we all know how this goes practically, and there's such great stakes in addiction and recovery, aren't there? Is that if the number one trigger for relapse is stress, and we're off relationally, then it's a really, really precarious position to be in. So all the more reason for us. I loved how you guys talked about it in your training back in Florida, where you start with meditation. You start with creating a space inside so that whatever the conversation is, at least it's based in being grounded in our psyches and our bodies in a clear space. Other questions or comments? Does this resonate for you personally? Does it resonate for you professionally, the work that you do? Yes, ma'am. Yeah.
So the work we do here can be really short term.
Yes.
And so for those couples that can, or families that can make it out, we have a family intensive weekend.
Which is great.
And that allows us to have a session with the family, with the couple. What would your advice be given? We've got 1 hour with this family who's newly in recovery and are planning on moving forward.
Yeah, good question.
Yeah. I think that one thing I would say is it's so important what your stance is. You know, unfortunately I do run into occasionally people who are helping, you know, counselors, and they have this sort of disdain for, like, you know, this AlAnon person or this loved one, you know, they're going to ruin it, and they're like, they need their own therapy. If you really start by just really understanding how upset they are and how hard this is for them, you have to have that down first. So just really getting and tracking with how this has been so scary. Remember, underneath, probably they're going to be presenting with more of the underlying emotions, going to be more panic, fear, you know, I'm afraid they're going to relapse, I don't know if I can trust this. Just really understanding that and getting that makes so much sense. That makes so much sense. And then letting them know that when they do get into a dysregulated state, they're going to affect each other, and that you probably will have disagreements and disjunctions. But what is it that you're both sort of fighting for? Are you both fighting for to help and assist in the recovery? How do you want to assist? Do you feel like you have it in you, and remember that that loved one's coming in with a reservoir of hurt, pain, and resentment. And so you really have to be there with them in that and get it. And I think that's really important. And then the other part, you know, I think is important, but if you get that piece, once they at least feel like they'll feel some sort of support, and then of course resources.
I used to teach a class in graduate school on how to get your client angry at you. We had a whole class session on how to get a client angry at you. And in a nutshell, it's to miss a tune. It's to be ahead of or behind, impatient with. And we would just do role plays in class where we'd break into dyads and just get each other pissed off. It happens so quickly, you know. There's so much at stake here. And if the therapist, the counselor is impatient, has some other agenda, the loved one is going to read that, feel that, and react to that, and it's a step in the wrong direction. So the answer is don't piss off our clients, but to really be with them. When we talked about authentic support earlier, again, I think it really gets back to countertransference. Are you all familiar with that? If I'm impatient inside myself, it will transmit through the air, won't it, to my client? So I have to really be clear inside myself what Colleen is saying. To have a really deep commitment to the addict and recovery. And I have to tell you, a lot of the study I've done the last 2 years has been on shame and stigma around recovery, and it's helped me to root out even more of my own shame and stigma about recovery. And I'm in recovery. So it's like it can get very, very subtle in there in terms of the judgments and the biases we have. Well, just as you would do for your work with the addict and recovery, to make sure that you're as conscious as you can be about any kind of lingering shadow there, very much the same with the non-addicted spouse. That person gets ignored in treatment, generally speaking. It's kind of an afterthought. And we're making the point here is that to do that at great peril for the addict and recovery. As Burkook, as I shared earlier, said, if you don't address both, somebody's going to die here.
Yeah, and I think that this piece that Bob's bringing in about the neuroscience and really understanding and having a realistic expectation, one of the things that I see that's so wounding for families and couples is that they'll come in so upset, they don't really, the addict maybe had, you might have seen like a huge improvement, like they're really trying hard, but they're still in that oscillating up and down phase, so the loved one sees them, starts freaking out like nothing's changed. So letting them know realistically that they may still really be having a lot of the same behaviors, and that's normal. And what can really get triggered is that if you start using this attribution like you're always like that, or you're just a bad guy, or you're just, do you know what I mean? Like sometimes there's so much anger and resentment that when they see those behaviors, they want to characterize as you don't really care, you're not really working at your recovery. And then what does that do? What does that make the addict feel? Defensive, exactly, and shamed, right? Because underneath the defensiveness is the shame. Always remember that there's a reactive layer underneath this, and I'm always looking when somebody's really angry or really defensive or really has a really strong defensive. I'm always wondering what is the hurting place inside, and if you can reach that, you've gotten somewhere, I think.
Makes me think of Mother Teresa. Right before she passed away, I read a book of hers where she would look into the eyes of the lepers in Calcutta that she would treat. And in her language, in her face, she said she saw Jesus in the eyes of every single person. That image comes back to me. It doesn't require for you to be Christian to be able to see the hurt, to be able to see. Sometimes what goes for me is I'll look at somebody as a grown-up, I'll look at myself, and I'll see that person as a little boy or a little girl, just to open up the heart of compassion. And that's a piece of it that we don't study that much in our training programs, right? But it's like the pearl of great price. You can tell if somebody's looking at you and turning you into an it, into a category, into a DSM diagnosis, versus you as a person, you as a living, breathing being, thou. Okay, you guys, just in the last couple of minutes, what we want to do is talk a little bit about our work, and then we're going to wrap up. And I want to thank you guys for your attention.
Yeah, you guys are such a great audience, I have to say. You co-regulate with me beautifully. You made it easy for me, yeah, so I really appreciate that. But Bob and I do trainings for different, for rehabs and facilities, trainings, people who work in addiction and recovery, really supporting
and universities,
staff.
so if you're in university,
Yeah, really working with staff and helping, train people along the lines of what we've offered here.
What we couldn't do today that we'd like to have done more of, and it's possible in a lengthier period of time, is to have you all doing the work. We just came from Saturday's presentation where we had a lengthy role play, 15-20 minute role play with audience participation before, during, and after, that kind of thing, where you're actually getting in and working with clients and developing skills. We love doing that.
Yeah, because what I didn't really get into is the fine-tuned work of what it looks like to work with a couple in second stage recovery. So let's say what we did in this last presentation, we looked at John and Susan when John had a year and a half, and they were doing well, but they still keep having these blow-ups and flare-ups because the underlying hurts and what we would call in the attachment field, attachment injuries, which are injuries to the relationship. And there are always injuries to the relationship when addiction is involved. That needs to be repaired in order for it to have safety and a robustness in the relationship that has a really good foundational support. So what does that look like? And that's when we bring in really Sue Johnson's approach and her theory, and she has a very, very well articulated theory that she's developed over the years. And then I actually did a role play with John and Susan from the audience, and I worked with them in real time. So you can see what it looks like. You can really get a feeling for the work. So it's not just kind of theory out there. It's really the theory and the understanding and then the practical application.
Thank you, guys. If you're interested in the PowerPoint, just email me or Colleen and we can send it to you from today. We're happy to do that. Love to be in touch with you. We're here local. We're up in Irvine several days a week. I work up just the road here.
As well. So yeah.
Really happy. I know many of you are probably practicum students or MFT interns and so on. Wish you well in your programs and feel free to be in touch. We'd love to be a resource to you.
Thank
God
you.
bless all of you. Thank you for your attention today.
Thank you.